Hey, I'm Dr. Burkhard Sievers, professor of medicine, specialized in cardiology, vascular medicine, gender medicine, and also a board member of the German Society of Gender-Specific Medicine. Gender medicine is gaining more and more importance and attention in Europe and especially in Germany, but the country where it all came from or is coming from is the USA. And the USA has the most experience in setting up the gender programs, and so does Dr. Katie Berlacher, who is my interview guest today. Hi, Katie, it's great having you.
Hi, thanks for having me.
Sure. So can you please introduce yourself and tell us a little bit about you?
Absolutely. My name is Katie Berlacher, as you so mentioned. I am an assistant professor here at the University of Pittsburgh Medical Center, where I am also the director of the Women's Heart Program, which is located actually in one of the many hospitals that our system is part of, called Magee Women's Hospital. It is a largely women-specific hospital, although we do have services for all genders. We mostly care for women here. Specifically, all of our OBGYN care is here, as well as a breast cancer center and some other oncologic services dealing with ovarian and uterine cancer. So I'm very fortunate to be here. My other job is to run a fellowship program. So I am the director of the cardiology fellowship program here, which is really, really exciting.
Oh, that's so nice. So as a German, I have to ask you about your last name. So
I know, right?
is it German or Austrian or Swiss?
It's German. It is German.
Oh, it is?
Yep. Although I now on the offhand, my mother is Italian and my father's side is German. And I don't know the small town. At one point, I knew the small town in Germany in which we are from, but Berlacher is. My grandfather was Franz Berlacher, and his father was the one that immigrated here initially. He was a milkman, and then involved in politics in Ohio is where I'm originally from. But yes, directly from
nice.
Germany.
So you're all international. I like that.
Yes.
So yeah, nice. So do you know any German?
I don't. I took Italian. German was challenging for me. Italian is easier. But yes, no, I love Germany in and of itself. It's a beautiful country.
You know, then I have another question. I read that you're a ambitious cyclist, boxer, and hiker. I'm curious, where's the boxing coming from?
Yeah, the boxing. That was something I kind of tripped on when I was growing up in college and in medical school. I took some classes just for fun, and then really liked it. So it is a fantastic workout, a really, really terrific, fun workout that requires a lot of speed and attention. And so it's one of those things that when you do that exercise, you really only can think about that, which is good for my brain to turn off other aspects.
That sounds great. So I have to try this too. So
you did. Yeah. I highly recommend it. I don't hit other, I don't fight. I don't like enter into fights with any other humans, but I do hit with my trainer.
Nice, yeah. So let's learn something about yourself in your Women's Heart Program,
sure.
Katie. Please, can you tell us, so where's your strong interest for women's heart disease coming from?
Yeah, that's a long answer, so I'll try to be concise. I actually grew up in a pretty large family. And when I went to high school, I actually went to an all-girls high school in Ohio. And that was really the first time that I was exposed to a gendered specific education, right? And, you know, it changed the way that I thought about the environment and how women were treated differently than men in society. And from then, when I went to college, while I was still interested in medicine, one of the things that I really like to learn about was how gender affects the way the world works, from a history standpoint, from a political standpoint, from a scientific standpoint. So I ended up majoring in women's studies, so a gender-specific studies when I was an undergrad at Duke. And then when I went to medical school, I was challenged with trying to figure out how to continue that interest moving forward. And as I watched much of medicine, I continued to observe differences from sex, but also differences in the way that genders are treated. within medicine, not only with regards to the actual treatment that they get, but with regards to communication, the workup, and those sorts of things. And, with my understanding of hormones, and my desire to better understand how those affect diseases in the heart, I was frustrated then by the fact that there wasn't as much data in that area as I had wanted. And so really that began the kind of dedication to trying to understand and support not only the science behind it, but also the patients who are looking for answers. And the more that I kind of learned, the more that I realized there was a gap in care for them. So when I came to training, I did training in medicine. We do 3 years of medicine training. And my residency, I did a focus in women's health. So I was exposed to a lot more of medicine from a gendered perspective or lens. So I did endocrine and cancer with a gendered lens. And at the end of the day, when I decided to do cardiology, I thought the gender lens was an appropriate one for us to apply to this field too. So I've been welcomed to it. It's been 10 years that I've been in practice now, and been about 15 since I've been thinking about it. And I by no means was the first. I think there's many other people ahead of me who thought about this, but unfortunately, I was one of the first to really grow a program and develop kind of a thoughtful, structured program around the care that we provide for women. So I feel strongly about that. I continue to want it to grow, and there's tons of ways that we can do that.
Yeah, that's for sure, and there's a lot to do. So, I noticed when I'm traveling pretty frequently between Germany and the US, and I noticed in the US there are a lot of women's health programs. So in Germany we just start, and there's not a lot, just few hospitals that offer this program. So from your standpoint, what does it need to start a women's health program?
Yeah, well, I mean, first you have to have the leaders who want to do it, right? So people like yourself that have the interest and the passion. You have to get support from the people who are in charge of the institutions who have money. That's the biggest thing, I think, is to buy in. That's actually been in recent years, and I'm curious what the experiences in Germany, but in America, we recognize that much of the finances of the home and the healthcare itself, decisions about healthcare, are oftentimes made by the woman of the household, typically a mom. And that then kind of determines where a lot of the rest of the care of the family will go. So if a mom goes somewhere, then the rest of the family typically follows. And so from a financial standpoint, that has really helped us convince a lot of administrators that if we deliver care and really focus care on taking care of women across the spectrum, not just when they get diseases of older ages, that we really can prevent some of those diseases and also kind of get a lot of them for the long run. So I think so. The passion, the financial support. I do think that you need people like yourself who have some expertise in the area. I think there's been some recently where this has been trendy and not followed necessarily with the expertise. And so you do have to know the data that supports and where questions remain and where there are differences between men and women and what hormones do and do not do. And so I think the expertise is also really important for everybody. And then the last thing that I'll say is a team approach. As a cardiologist, I don't function in a vacuum. I need an endocrinologist and an oncologist and my primary care team and neurologist. So it's really helpful to have a group of us that can work together with OBs and whatnot to make sure that we care for all of the women from different sides of things. And I'll say this, you started off by saying gender studies, and I really appreciate that because I think for a long time we've really focused on women specifically. And while I think there's a big need and the biggest need for that, there's a lot of work recently that is looking at the gendered spectrum and what testosterone and some of the hormonal uses from that standpoint can do. And so I think I love that term. It feels very inclusive to me. So thanks for using it.
Yeah, so thanks for the insight. There's a lot of, and I think the interdisciplinarity is very important. So that is one of the key points, because not only about cardiology, it's also about all these other subjects around, right?
Yeah. Yeah, I actually, right after our meeting today, in about 2 hours, I have our monthly meeting with the maternal fetal medicine experts, where all of the cardiologists, the adult congenital specialists, our anesthesiologists, and our OBGYN and maternal fetal medicine experts actually all get onto a call for 1 hour in the month and review all of the high-risk patients that are in their 3rd trimester, so that we can make sure that we all are on the same page about their plan for delivery, which has been really helpful. So
it's in regular conferences, right? Yeah,
yep, it's a monthly, the last Tuesday of every month, or the second to last Tuesday of every month, I guess, is when we do it.
Yeah, that's a good idea. So to bring our people together then. So it is mainly also something women have to know about. The women out there, they have to know about the program. So how do you manage to raise the awareness of the woman for cardiovascular in your town or nationwide even?
Yeah, I think that's a great question. And I think it has to be multi-pronged, right? So we can start small. I think the grassroots and the local efforts are really important for us to get the word out. I work with my marketing team for the hospital and the system to make sure that we have a website that has patient information, short little blog videos. We do some patient stories. We have an entire list of diseases that they can click on and get information at. So we do have that for our office and our specific services here. We work really closely with a lot of the societies like American Heart Association, American College of Cardiology, and then there's some women's health societies and some OBGYN societies that we all like to do some advocacy for. So a lot of public panels and public webinars to go speak, to talk about exactly what you're saying, which is that this is unfortunately the #1 killer of women. Is heart disease, and that if you can pay attention to it and treat the risk factors aggressively, much of it can be prevented. So there's an element of control and empowerment that we like to give to our patients.
Yeah, you can actually prevent like 70 to 80%, right?
Yeah,
so
I know it's really empowering once they know that information and the resources that we have to offer them, right? So we can talk about how to get a blood pressure cuff and take it at home, and how to meet with a nutritionist, and exercises that they can do to be in better shape. So it really has been quite helpful from that standpoint.
Katie, when you do you have a outpatient clinic for those women?
We do, yeah. So we have in the Women's Heart Center. I'm actually physically here today. In the Women's Heart Center, every single day we see about 15 to 20 outpatients in the morning, and then in the afternoon we round on the inpatients. So any of the patients that are here, whether they're here for delivery or they're here for chemo or any other complication related to their heart disease. So, and then we work in conjunction. This is a very big system. I work in a large hospital system. So we actually don't have some of our cardiology services here. So cath labs and EP experts are at some of our other hospitals. So I work in conjunction with them. Whenever we get those needs, we'll kind of transfer or rearrange. Likewise, most of our obstetric care is actually all done in this hospital. So any patient that's pregnant elsewhere in the city gets then sent to us, so that there's a concentrated expertise for that. Because as you probably know by now, most cardiologists are not super comfortable with obstetric care or contraceptive issues. And so that is part of the expertise that we think is really important if you are going to care for women, or when you decide to care for women that there really is understanding all of those aspects, not just, the cardiovascular issues.
So what would you say are the three most common symptoms of your patients?
Oh, of my patients. Well, I have a slightly different spectrum of patients than I think most cardiologists do. I'm lucky. I see of my patients, I actually see about 90% women at this point here in this office, which is really fortunate for us. That was the entire goal. Most of the time, I would say that shortness of breath and palpitations are probably the first two symptoms. Chest pain actually falls lower on the list, and I'm struggling to even think if I would say that's even the top three, the third one. Many of my patients, we see a lot of patients who have autonomic disorders, and so the postural orthostatic tachycardia syndrome, so POTS, and some lightheadedness and dizziness will be other things that they share with us. Those would be the kind of top 3, 4, 5. I don't know. I might have cheated there.
Yeah, I agree. The same in our clinic. Yes. So, Katie, you being the program director of cardiovascular fellowship, you're especially involved in education, of course. So,
I am. I'm lucky.
How do you implement gender-specific medicine in the medical education?
Yeah, we do. And that was something that was later to come. I started that part of it a few years back now. So, I've always had the option that if fellows, will do their outpatient, they have a couple different outpatient experiences. And so every year I have a fellow who, or actually I have 6 fellows now who spend a half day in clinic with me for their continuity clinics. So that's been wonderful. That tends to be fellows that are interested in gendered medicine so that they can train under me for a prolonged period of time. But what we started to do and what I recognized a few years back was that everybody really should, regardless of what you end up doing long-term in cardiology, you should have exposure to this during your training. And so we mandated that all fellows spend 2 weeks with us on the inpatient and outpatient services here to get exposure to the high-risk pregnancy issues that we deal with, as well as the oncologic specific to breast cancer and ovarian cancer here. And they love it. I think it's been an area that they would otherwise not see in totality, or at least in depth here. So it's been a really great experience. We're lucky to have a place like this where we can really encourage that type of education.
That's important that they at least everybody has to know about it and be aware.
Exactly.
Yeah. It's not only cardiology; it's all the other subjects too. But well, you talked about the pregnancy, and that is one of your area of expertise: women's heart disease, pregnancy, and also the heart disease risk. So we all know that women with hypertension, diabetes, or depression during their pregnancies have higher risk to develop cardiovascular disease later on. Can you tell me a little bit more about this?
Yeah, we're continuing to understand what that means. The question is, I think we still don't know exactly what the causality is versus if there is association, and understanding pregnancy as one of those windows into future life has been really helpful. There are some theories that that what happens during pregnancy would be the event that then causes harm for the future. I'm not quite convinced that that's really going to pan out as the explanation from a pathophysiology standpoint. My understanding and my guess is that there is underlying pathophysiology that the stress of pregnancy then reveals, and depending on what happens during pregnancy. And one of the things that you talked about is high blood pressure and diabetes. A couple of the other things that we've been looking at recently is actually not what happens to the mom, but what happens to baby. So if the baby is born and is a low birth weight, or born really early, preterm, those also portend increased risk for cardiovascular disease in the future. So I think it's been really helpful for the science to really evolve and grow, so that as we are taking care of patients, and really honestly, even if I don't care for that woman when they are giving birth, but maybe I meet them in their 60s and I talk to them about some symptoms that they have and what their risks are. I recognize now and try to teach others that it's vital for us to also take a pregnancy history, even in the postmenopausal person, right? That understanding my 62-year-old will kind of be like, why are you asking how many kids I have and how many pregnancies I've had and what birth weight they were? Like, why does that matter, right? Because it really does help me re-stratify them for whether or not I think they have some underlying disease and how strongly I should feel about getting further stress testing or echoes or imaging. So it's been really important.
Sure. Do you have any scores then that take account for these additional risk factors?
Not good ones yet. I think there are some that are being published in the very near future. I actually just recently saw one of an applicant that interviewed to come here for fellowship has created a score that uses some of those data points to predict. As you know, I think that, you know, what we have been using across the world is CarPreg score and Zahara, but those really don't predict the future cardiovascular risk. That's really just what the risk is during pregnancy. So we've started to include things like gestational hypertension or preeclampsia and gestational diabetes into modifiers of the risk scores, but I don't know a complete new score as of yet. Do you? I would, if there is one that I don't know of, I would love to learn about it.
Well, I don't know either. So, but that would be important to implement these additional risk factors in some kind of risk model, so you can actually predict the risk and which is taking this into account.
Yeah, I agree.
The other thing you're interested in and is and you co-authored an article which is called "The Urgent and Ongoing Need for Diversity, Inclusion and Equity in Cardiology in the US," and that is something that is also very present and has to be changed in Europe and Germany too. So why is it so important from your standpoint, and what needs to be done to change it?
Yeah, this is something, again, I feel very strongly about. In order for us to deliver care in the way that we want to, I think much of the workforce in cardiology should reflect the patients that we are seeing and caring for, because we all know that diversity of thought aids us with regards to our treatments, our understanding of things. And so if we bring diversity across genders, across races, across sexualities and backgrounds, we really take better care of our patients. We can bond with them better, we can communicate with them better, and hopefully decrease the bias that we bring to that relationship. And so this is not going to be something that we can change overnight. This continues to be something of a long-term goal, because training a new workforce really does start at very, very young ages. So I run some programs looking to expose high schoolers to the field of cardiology, trying to get them to be excited about it, because if we get them then we can help them through the path as they grow up.
Yeah, no, that's interesting, and it is well, obviously it is like diversity is helping to treat patients better, but also diversity is much more fun working as also the medical stuff together, because I always like being in an international team with different cultures and everything. So it's way more fun than only have one group of people with same culture and everything. So
I agree.
So, Katie, last question. What are the most surprising or exciting research findings for you regarding gender medicine?
Oh gosh,
just recently.
What is the most? Yeah, well, I mean, the one my favorite article in the past year was the CHAP trial, the chronic hypertension and pregnancy trial, which was a late breaker at ACC 22, and that really gave us evidence to further be more aggressive with the treatment of blood pressure during pregnancy. This had been something that I had been convinced of for a long time and was trying to convince my OB/GYN partners when we were caring for patients that 160/90 was way too high, and that we really should try to drive them down. But it was so helpful to have some very clear data that it's actually beneficial from an outcome standpoint, not only for mom, but also for baby. So I'm thrilled about things like that. I look forward to the long-term follow-up of the things like CHAP, but also to understanding better the medications that are potentially safe to use in pregnancy. I think we're also starting to look at statin use in pregnancy and when that's appropriate. So I'm very much so looking forward to the outcomes of some of those things, which I know are due in the next few years here.
So what would be the ideal blood pressure for a pregnant woman?
Yeah, so for women who have any sort of risk from a cardiovascular standpoint, we recommend that along with the trial to keep it less than 140/90. So we would actually start treatment if patients were consistently higher than that. Whereas before, there was kind of various numbers at which point the treatment would be started, but most of the time it was started at much higher levels, sometimes not even till above 160 systolic.
All right. Well, Katie, thanks so much for sharing all this insight and your expertise with us. It was very, very nice talking to you, and was a pleasure meeting you online. So thank you so much.
Likewise, Burkhard. I hope this is a long study for you, and you talk to lots of people. I'm very excited to see what you find out and what you learn. I hope you share all those outcomes and findings in social media and beyond.
Yeah, I will share it, and I also love the networking which comes with it.
Awesome.
So
same.
Thank you so much.
Good. Well, it was lovely to meet you, and keep in touch. Okay.
Yeah, sure. We will. Thank you so much.
You're welcome. Bye-bye.